Welcome back to Core Anesthesia. Whether you are a student prepping for tests and boards or a CRNA here to earn CEUs, we are glad you've joined us. For more about us, make sure to check us out on Instagram at Core Anesthesia and online at coreanesthesia.com.
Welcome back to Core Anesthesia. I'm Cole, here with Tanner, and today we're going to do a discussion about OB anesthesia, specifically regarding epidurals and spinals from the neuraxial anesthesia side of things. How is it going to look from the very basic first step? You get paged to go in and place an epidural on a patient, or you have a scheduled C-section and you're going to be planning a spinal anesthetic for them. This will obviously vary slightly from when we do spinals or epidurals in the main operating room. And we wanted to walk through what is the process that it looks like to do that, to both place an epidural, place a spinal. We might go through a cerclage type procedure where you would do more of a saddle block-like picture. And then we'll talk about some of the medications that we would put in these epidural mixtures, some adjuncts that we would use both in the spinal and the epidural, and how we would be able to best provide pain relief to these patients. So, Tanner, do you just first want to walk us through just a brief overview of the anatomy of the spinal cord and what we're going to be trying to go through from an anatomical perspective here?
Yeah, absolutely. And remember, when we're talking about the spinal cord, it's easy to just separate it into several different sections. So you have the cervical spinal segments, so that would be C1 through C7. You have your thoracic spinal segments, that's going to be T1 through T12. You have your lumbar region, and that's L1 through L5. You have your sacral, which is going to be S1 through S5. And the reason that's important is because when we're talking about landmarks later on, and we're talking about, the different locations that you're looking externally on a patient to identify where you're going to be placing these, whether it's spinal or epidural, it's important that you have a good understanding of, one, the different spinal segments, so you know where you're actually going to be placing this. Two, you need to understand the curvature of the spine. It's helpful too when you're trying to get them positioned properly so that we have a better shot of getting, really good access here. The other thing we want to talk about is the actual layers that you'll go through as you are placing either a spinal and epidural. The first thing is going to be the skin. That's, really obvious. And then the second thing that you'll be going through is typically some amount of subcutaneous tissue as you are placing the, again, spinal epidural. If you remember what a vertebral body looks like, it's helpful if you pull up a picture while you're listening to this audio. I'll try to do my best to explain here, but you have basically the vertebral bodies, and then coming off the back posterior to the vertebral bodies, you have these spinous processes. So if you feel on your back right now, you can feel those little knobs or the little bony prominences. That's going to be your spinous process. So for the first thing that you'll encounter as you are placing the needle here is going to be the supraspinous ligament. So that's connecting basically the most posterior portion on a patient that the spinous processes all the way down. In between that, you're going to have the interspinous ligament. And then really the main ligament that we think of is going to be your ligamentum flavum. So that's going to be right there as you pass through the interspinal ligament. So now you're through the spinous processes and you're getting there towards the vertebral bodies. That's where you're going to have your really thick ligamentum flavum, which is going to be that thick ligament that you're really going to feel resistance as you are pushing your TUI if you're doing an epidural, or your spinal needle as you're placing the spinal. As you get comfortable placing these, that's really going to be like the hallmark sign when you get your needle into that ligament, where you know exactly where you are. You're going to feel a very different feeling there in that ligamentum flavum than you're going to be feeling as you are encountering bone, as you are trying to get into that space. And you'll notice that it's still tough as your needle's passing through it. It feels like you just threw the brakes on as you're going through, subcutaneous tissue. Your needle will go through much easier than when you get there to the ligamentum flavum. When we're talking about positioning, we'll get into a lot more of this as we move forward. But when I mentioned earlier, understanding the curvature of the spine, the lumbar region, where we're really going to be focused on placing these devices, these needles, think about those spinous processes will tend to angle down towards the feet of the patient. So it's going to be, angled down caudally from the patient as they're sitting up on the side of the bed to help with your angle of needle placement as you have them drop their shoulders down, as you have them put their chin to their chest. There's a million different ways we, describe this. People say like arch your back like a mad cat. People say try to look like a boiled shrimp. There's like, depending on which area of the country you're practicing in, they all have their different ways to try to help patients understand this. But you really want them to be pushing out and inverting that natural curvature of the spine. You know that your spine will kind of bow out going through the thoracic region and then will invert as it's going through the lumbar region. We want to basically change that, have them roll their shoulders down and stick out that lumbar portion. What that's going to do is help open up those spinous processes. And that's going to allow you to have a better shot as you're trying to, again, the first step here is just getting to that ligamentum flavum before we, even go any further about talking about getting into any of the spaces. Really what that's doing is opening up those bony structures so that you have a clearer shot as you try to advance your needle.
Yeah, I like to always tell patients to basically do an ab crunch, which is a lot easier said than done around a womb. But if you think about trying to do an ab crunch while you're sitting up, the lower third of your back, I'll usually be feeling for landmarks at that point when I tell them. And I'll say, you feel my thumb rubbing the lower third of your back? Try to do an ab crunch and push that part of your back towards the back wall. And that usually helps them get in that good position. Otherwise, a lot of patients just bend at the hips, and that doesn't do anything for us. We need that arched back in a big C-like position.
I've never heard the ab crunch, and I will admit, I would imagine if you're listening to this, you're like me. I'm like sitting here doing it, and I'm like, yeah, it actually works. Like,
the crazy looks that I get from the pregnant ladies that are in labor when I say do an ab crunch, they're like, "What abs? I have no
like,
abs."
I've done enough. leave me alone.
But it works though. It really does get them in that good position, and we need that. Positioning is key. I mean, it's similar to intubation. I mean, positioning is key in a lot of the things that we do in anesthesia. So before we get into the process of doing this now, what's the goal of an epidural? We'll talk about epidurals first. So the goal is to access the epidural space, which is going to be, as Tanner said, after you go through the ligamentum flavum, you'll enter a potential space before the dura mater. And that is going to be the epidural space. And nerves that are branching off from the spinal column are going to come out and branch out into that paravertebral space. And we're going to be putting medicine or medication into the epidural space, which will go around to that paravertebral space and coat those nerves. And the local anesthetic in the epidural will go ahead and block the sodium channel in the axons of these nerves and block the pain then that is being transmitted through them. Secondly, we also will add opioids into this medication as well, and that'll work in the dorsal section of the spinal cord, in the substantia gelatinosa, which will work on receptors at that spot. And then there's also adjunct medications that we'll talk about later on as well. Now, it's important to know here that when we're placing the epidural, depending on what stage of labor they're in, will depend on what nerves we want to target. If they're in the first stage of labor, we're going to want to cover the T10 down to L1 dermatome levels. And then as they get closer into the second stage of labor, so baby is closer to actually being delivered now, you can imagine then as baby's head moves further and further down the birth canal and ready to come out, we're going to be putting pressure on different nerves. So at this point, in the first stage of labor, it's mainly the uterine contractions and the cervix that's dilating. And that's why we want a higher dermatome level blocked. But now that we're going to be getting closer to delivery, in that second stage of labor, we want to extend that epidural to cover the S2 to S4 dermatomes. And again, we'll talk about how we do that as we move through this. So to place an epidural, most often this is going to be performed with using what's called a 2E needle, which is going to be a 16, 17, or 18 gauge needle with a blunted tip at the end of it. And the reason that's blunted is we want to get through those ligament layers that are very tough layers, but we don't want to pierce the dura layer on the backside of the epidural space. It's a very small margin that we're trying to place this epidural at the second we get through that thick ligamentum flavum, but just before that dura mater. And with that blunted tip, we're hoping that it's not going to pierce through that dura mater on the far side. Now, oftentimes these 2E needles, depending on which one you're using, will have a curved end to it, which will allow the catheter, when you feed it through the inside of this hollow needle, it will then move in the direction of the head of the cephalic area once you get into the epidural space. So you'll see a curved end to these 2E needles. Now, when I get a call to place an epidural, the first thing that I'm going to do is obviously look up the patient to make sure that they are appropriate for an epidural. So things I'm looking for is, do they have any contraindications? Well, the main contraindication to doing this would be if they refuse an epidural. That's obviously number one. We're not going to do that. But if they're asking for an epidural, then I want to make sure that they have no blood clotting disorders, that their platelet count is above a certain level. And this will vary from provider to provider. Some providers will go as low as 75,000 on their platelets. Some don't want it below 100,000. Personally, for me, I can go below that 100,000 level and closer to 75,000, given that they are stable at that level and that they're not dropping. For example, the other day I had a patient who was 85,000, and I saw that 3 weeks prior she was 200,000, and a week prior she was 130,000. So I said that obviously is a very steep drop. Something's going on to cause that drop. I don't feel comfortable doing that. And the reason we check for platelet counts is because the epidural space is full of many blood vessels. And when we go to remove that catheter after they deliver, or even during placement, we can traumatize some of those blood vessels, and you can get an epidural hematoma and put pressure on the nerves and cause some damage to the nerves descending through the rest of the body from there. And so that's obviously something we don't want. So I want to make sure their platelet count is stable. And again, depending on the provider, at least 75,000, 100,000, somewhere in that range. Secondly, I make sure they're on no blood thinning medications. And you can look at different charts that'll walk you through how long they need to hold those different blood thinning medications before you can place and remove an epidural catheter. And there are obviously more relative contraindications to doing an epidural, and that will just kind of depend on provider to provider. And in certain situations, such as hardware in the patient, previous back surgeries, fusions of different levels of the spinal cord. Obviously, if they're fused throughout their entire lumbar region, you're going to have to do a thoracic epidural, and that's something that a lot of providers may choose not to do. And so again, that's a person-by-person basis. So once I get into the room, I go ahead and get a history for the patient, do a pre-op assessment, and then walk them through some of the risks and benefits. And obviously, if they're calling you in to do an epidural, most of these patients are in a lot of pain. And from what I've found, it doesn't do a lot of good for you to sit there and do a 10, 15-minute thorough preoperative assessment on these patients and go through all the risk and benefits like you would if you were in the preoperative setting before a main OR case. These patients are half listening to you, and they're just wanting to get out of pain because they're blinded by that pain. And so you need to read the room when you go in. If it's somebody who's earlier on in their labor stages and they don't seem to be in as much pain, you can take the time and go through that with them. Otherwise, if they're in extreme pain, I am talking as I'm setting everything up and trying to maximize the time that I have and be the most efficient. And what I usually will walk through with them is, as Tanner mentioned, getting them in that good position, sitting on the side of the bed. I walk them through the concept of what we're trying to do with the epidural, and it's to take away that sharp pain with their contractions, but they may still have a little pressure or tightening. And then I walk through some of the risk and benefits. So I tell them there's several different layers in your back, and one of those layers is the epidural space. That's where we're going to try to put this catheter. But obviously, we're not in there with a video camera. We're feeling our way through these different layers. And when we think we're in the right spot, we'll go ahead and thread that catheter, and then we'll test it with some medication. There's always a chance we're in a wrong spot, have to take it out and put it back in. Now, one of the layers we could be in, though, increases your risk of having a really bad headache for a few days. And that would be if we go through the dura layer and we cause what's called a wet tap, as we'll get to in a few minutes here. And that can cause a post-dural puncture headache. And I tell them I'll know instantly from that layer, and there's things that we can do at that point to try to minimize the severity of that headache. But it's only a temporary headache for a few days, it's not permanent. And then secondly, I'll talk about infection risk while we do this sterilely, et cetera. And by that point, they are usually ready for me to get this epidural in at that point. And I continue to walk them through the process as I set up their back, I feel for the landmarks, et cetera.
And like Cole said, depending on the stage of labor and depending on what the room is like, it's going to, differ on how you're communicating. But I think it's always so important, especially with spinals and epidurals. The patient is in such a vulnerable position as they're facing away from you and you're working behind them. It is so key, I think, as you build trust with the patient to just communicate everything that you're doing. Even from if you're doing a spinal in the OR and you're feeling for, the iliac crest and trying to determine your space, your hands might be cold and they're nervous. And I've seen it so many times. People just go and they put their hands on, someone's back trying to find a spot. The patient jumps because their hands are freezing. And it just like small little things like that it's crucial that you're communicating every step of the way. And I like to tell patients that nothing's going to be a surprise from here on out. I'm going to tell you before there's ever a stick with a needle or there's, even the cleaning, the prep that I'm using. I'm going to tell you before anything is happening because you're just back there working. They're nervous. This sounds like a really scary procedure. If they're in labor, there's a million other things that are going on in their minds. And so, like Cole mentioned, you're setting up, you're working, but it's also so critical that you're clear and concise with your communication and then just give them the courtesy of communicating to them while you're doing every little thing and build that trust. Like Cole mentioned, position is so necessary as they are trying to, get positioned to do the procedure for the epidural. Most of the time, if there's not a contraindication, we're going to have them sitting on the side of the bed. You can also have them laying on their side. Sometimes that's helpful if you're really having trouble with them sitting on the side of the bed, or maybe they're not able to sit as still. I've had some success with having them lay laterally on the bed, and that seems to give them maybe a little more stability if they're really jumpy or if they're just having a difficult time getting in that position of sticking that lower part of their back out. The next thing we want to do is determine our space. And so the best way to do this is you're going to feel with your hands the top of the iliac crest. And so you'll be feeling there with your hands on the side. Join your thumbs there in the middle. That's typically your L3, L4 interspace, which is where we like to start. Sometimes if you're having difficulties, you'll need to go up a level or down a level, but that's a good place to start when you are trying to identify the best place here for the epidural. The next thing we'll do is prep the skin and drape. Everybody does this a little bit different as you're marking. Some people will use a skin marker and mark, or I don't like doing that personally. I'll usually just do a little indentation with my finger where I'm feeling. And by the time you prep, you're still usually a little bit of an indentation there when you're getting ready to start placing the needle. You can also re-identify your landmarks after you've sterilely draped and have your sterile gloves on and everything. And many times if you have any kind of indentation there, if you can't see it, you can still feel it. It's just helpful to kind of reorient yourself. The next thing we like to do is to do a little lidocaine on the skin and then advance that as far as you can to try to numb up the path of the larger needle that we'll be using for the epidural. It's really important when you're doing this. Again, this is the first really part that's going to get uncomfortable for the patient, other than obviously they're in labor and they're hunching over in an awkward position. But this is the first time that we're actually using a needle. And so I think it's really nice as you're using that really, really small needle, just get right underneath the skin and inject a little bit of lidocaine. You'll get your skin wheel there. And then as that starts to set up, there'll be a little burning that they'll feel. But as that starts to set up, you can start to gradually go deeper with that lidocaine. This is where you want to spend your time getting a really nice numbed up area. A little more time here, a little bit of discomfort here is going to save them a lot of pain and pressure as you go through the rest of the procedure. And I think initially starting out, I was really quick on this. You're just wanting to get to the next step or the more difficult portion. But this is important. You take the time to really numb up the area. The other thing you can do with this is if you have difficulty locating a spinous process, or you're not quite sure if they've got some curvature in their spine or whatever, you can use this needle as kind of a seeker needle to start and to try to identify. You'll start to get the feel of kind of as the needle rolls off the spinous process, or as if you're getting into just sub-Q here, or you can feel the process go away here. You can get an idea of what the spine is looking like initially just using this little needle that you're using for your lidocaine. And so a lot of times, especially with my spinals, we'll talk about this later, I'll use that to kind of identify trajectory of where I am going to be placing my actual needle, because I can tell, hey, I'm hitting spinous process here, but if I go at this angle, I'm clear. So I'm probably going to step down just like a touch lower and then go at an upward angle to achieve my actual spinal or my epidural. So there's lots of reasons that we're numbing the skin. It's nice for the patient, but you can also use this for your own benefit as you're trying to identify landmarks and understand the anatomy of their back.
And as Tanner mentioned, this part is just so key to take your time on. And I try to time this while they're having a contraction, which may seem backwards, but if they're distracted with their contraction, I'll usually just tell them, or if they're not having a contraction, I'll just tell them you're going to feel 2 rounds of pain, 5 seconds each. Take a deep breath and hold it. And then I go that little pinch and a burn, and they slowly exhale that over the 5 seconds. And as Tanner said, if you take your time here, you should set yourself up for success where the patient theoretically should not feel any pain after this point, which is why even if I feel the trajectory I want to go, I will still numb several different angles that I potentially may alter my trajectory. That's where you get into trouble. If you numb a certain trajectory, then you go with your TUI needle and you have to redirect later, well, they're going to be in a ton of pain because now you're going at a different angle you didn't numb. So if they're already ready for this burning sensation, just numb a few different angles that you might be doing, and then you're going to save yourself so much issue down the road. So
100%. It's like, I think starting out, Cole, I was like, I don't know. I almost used it kind of like when we're pushing lidocaine before propofol and induction. You're like, this probably helps, but it's like, sometimes they still complain of burning or, whatever. And kind of behaved like that with my local when I was doing, spinals or epidurals. And the more you learn, like the better you get at that first step, like the whole procedure goes so much better. The patient's moving less, they're complaining less. You have more time to make little adjustments or whatever because they're not, feeling pain, or just think it like is massively beneficial as you learn to take your time there.
yeah, it's satisfying for you and the patient when you finish and they're like, oh, I didn't even feel that. You're done already?
Yeah, for
And I'm
sure.
like, yeah. And I will say more times than not, when I take the time to localize at the beginning, a patient, when I get done, will say either A, that was so much better than last time, or if it's their first time having an epidural, they'll say that is not near as bad as what I thought in my head it was going to be. And it's because the pain really was that initial numbing medicine when you get like your IV, a very similar feeling. Well, anyway, moving on. Now that you've localized the patient, they're numb, you figured out your landmark, we're going to go ahead and put our TUI needle and try to get placement into the epidural space. And what you want to do is once you felt that L3, L4 interspace, maybe you decide to go up one, down one, wherever you decided to go, you are going to go into that same exact spot that you already localized. And I usually tell patients you're not going to feel sharpness, but you're going to feel some pressure here. And then it's going to feel almost like a gritty sensation as you're going through ligament. When you go through skin and subcutaneous tissue, it's going to be relatively easy. But you're going to be able to tell holding the TUI needle when you get to first that supraspinous ligament that's running top to bottom all the way down the tip of those spinous processes. Once you cross that barrier and into that first ligament, you're going to start to feel this like gritty pop, 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 pop kind of crunchy sensation. And the patient will feel that. They'll like almost hear that vibration inside of them. And so just tell them ahead of time, you're going to feel a crunchy sensation. That's normal, but it won't feel sharp. So you pass that supraspinous ligament, and now if you've put your trajectory correctly, you'll be able to pass between the two spinous processes, between the two levels that you're trying to work on, and you'll enter into that interspinous ligament that's running top to bottom between those two spinous processes. If not, if you're hitting bone at this point, you try to adjust either elevate the angle or sometimes go flatter and make it more horizontal, and just kind of walk depending on where you're at and where your injection point is. This is the part that you really need to have them in good position, and they need to really curve that back and open up the overlapping shingles, so to speak, of those points coming back. But once you get through that second ligament now, the interspinous ligament, you'll be able to tell because you'll be able to walk, another 2 centimeters further in with that needle, and then you'll start to feel it really engage into a thicker ligament. Sometimes you almost have a little bit of a gap space where you stop having that gritty sensation after the interspinous ligament, and you almost feel like you're easily moving the needle forward. This is the part where you really need to take your time at. You want to be hooking up a syringe, which is going to be either filled with just air or saline. Personally, I like to use saline. And I'm going to be trying to inject this saline as I'm advancing the needle. And when you're engaged in ligaments, you're not going to be able to push that saline in. But when you enter the epidural space, it's a negative space. Basically, it's a potential space between two layers. And so it's going to accept and take in that saline that you inject, or air if you're using air. Now, if you're in like a free space in between ligaments, though, if you're pushing on that syringe hard enough, you will be able to inject a little bit of either air or saline. So you got to be careful that you're not over forcing it. I mean, it'll be really easy. It'll be able to push pretty easily when you're in the epidural space. So after I've passed the interspinous ligament, I continue to advance until I really feel it engaged in a third thick ligament. And it'll be a lot tougher to pass this 2A needle through, but it'll feel different than osseous and bone. Bone will just feel like you're hitting a brick wall. This, you'll be able to continue to push it forward. It'll just be tough. And this is where you really want to slow down and just advance millimeters at a time. Because the second you pop through this ligament, you're in the epidural space and you don't want to go any further because that next layer is the layer we don't want to cross, the dura mater. And once you cross that ligamentum flavum, you'll almost feel the needle just pop free and you'll be able to tell that it advanced easily through. And then I just go ahead and push my fluid just about a cc or two to make sure it actually goes in. And then personally, this is where I differ a little bit in how I do an epidural. You can either at this point thread your catheter straight on through, and because the 2A needle has a tip to it, a tip that's pointing upwards, then the catheter will go through that needle and then it will turn and head upwards and run up the back, up the epidural space. And your goal is to leave a couple centimeters extra of this catheter in that space so that one, it doesn't pull out. And if you do pull the catheter back a little bit, there's still going to be a little bit left in the epidural space. But two, the end of this catheter has little small perforations in it that allows the medication to come out. And you want to use the length of the end of that catheter to allow several different spots of medication to be released to cover those nerves. So at this point, you look at your 2A needle and there's markings on them, basically a centimeter for each marking. And you want to see, well, how many of those markings are you into the back to reach the epidural space? And let's say it takes 6 of those markings to get there. Then you know you need at least 6 centimeters in the depth of your catheter to get to the epidural space. And then you want another couple plus from there. Some people do 3, some people do 5. It just depends on provider preference. So let's say you wanted to do 5, then you would go a total of 11 distance on your catheter, and then you'll pull the needle back out over that catheter and leave the catheter in at a distance of 11 on your marking at the skin. That gives you the 6 to get to the epidural space and another 5 running up their back. Before you get to this point, though, this is where I like to do something a little bit different. And I like to do a purposeful dural puncture, which sounds backwards because I just said you do not want to go through the dura mater. The reason is you don't want to go through with your big 2A needle, which is a big needle, a 16, 17, 18 gauge needle. And if you do this, it's going to create a big hole in that dura layer, which will allow cerebrospinal fluid to leak out. And if this does happen when you're placing an epidural, it's not the end of the world. It's not something we want, obviously, but it's not like the patient will die from this. There's things that we can do to correct this. But what's going to happen is you're going to see immediately like a waterfall coming out of the end of your 2A needle, and it's just going to be pouring out cerebrospinal fluid. But if we're in the epidural space, we think we're there. Before I thread my catheter, I will purposely take a small 25, 27 gauge spinal needle, and I will go through the 2A needle. And sometimes the 2A needles will have a little hole at the very bottom instead of it bending upwards to allow that spinal needle to go straight through and go an extra centimeter through the dura layer into the cerebrospinal fluid. And I do that for 2 reasons. One, I'll be able to check with that spinal needle when I pop through. If I get CSF leaking back, it'll be so small amounts, it's not going to cause a dural puncture headache afterwards. It should not. But it verifies for me that I am in the epidural space, that next layer really was a cerebrospinal fluid. And so I'm in the right space. 2, the epidural space is round. It goes around the spinal canal. And theoretically, if I'm just a little bit off to the side, I could be in the epidural space, but I'm on the left or right side. I'm not in the middle. And this means I'm much more likely to get a one-sided block, and the patient's going to have a lot more pain on one side because the nerves are numbing that other side. So this tells me 2, that I'm in the middle. And 3, by making that little hole, it allows for some of my epidural medication later to leak a little bit through into the cerebrospinal fluid and get a better spread and a better block. So that's why I like to do this, but you don't have to do this. But like I said, you thread your catheter, pull the needle out, and then we hook it up and we're ready to test it with a test dose.
When you're giving this test dose, you usually will give 3 to 5 cc's of lidocaine with 5 mics per mil of epinephrine. The reason we do this is because, like Cole mentioned, the epidural space is full of different blood vessels. And so if we have advanced our catheter into a blood vessel, then we'll see very quickly that the epinephrine that is in that lidocaine will increase the heart rate and the blood pressure. The lidocaine that we've given, if it's again in the blood vessel, you could see ringing in the ears with the patient, metallic taste in the mouth. So those are things that you are going to be communicating with the patient as you're giving the test dose. Like Cole mentioned earlier, when you're talking about all the different risks and all the different steps of the procedure, you're going to mention that up front, that there's potential for malplacement of the catheter. And that's a good time to mention that, I'm going to ask you questions about if you have ringing in the ears or, the different tastes in your mouth. But this is also, as you're giving the test dose, you're going to be telling that to the room so they can start timing and helping you keep track of vitals. You're also going to tell the patient, okay, I'm giving that test dose now. Let me know if you have, that ringing in the ears or, different tastes in your mouth as I inject this. If it is going to be in the intrathecal space, so if it's an intrathecal catheter, you'll see numbness, tingling, or weakness down the legs almost immediately. And so that's something that will also be a conversation you're having with the patient to let them know what kind of symptoms they're having as you give that test dose.
Right. And when you are giving this test dose, typically it'll happen within the first 30 seconds if you're going to have any of those side effects. And this can happen even if you aspirate the catheter before you inject. And I'm always looking for blood in the catheter. And usually if I'm in a blood vessel, you'll see blood coming back in the catheter. But there's been times where I haven't, and I've given the test dose and instantaneously they have these symptoms. And you have to redo the catheter because at that point, you're just basically putting an IV in their epidural space, and that's not going to do any good for them. But if they have no symptoms that we asked about over the first 30 seconds to a minute, I'm going to go ahead and tape up the epidural. You want to make sure this is reinforced with tape really well, tegaderms, because we're not suturing this in. At least most of the places I've done this at, we don't suture this in. And you don't want to risk this thing sliding out. And so we tape it down really good, lay them back, and then we're going to start our epidural infusion. And this is where it'll differ from provider to provider. Typically, I will give a bolus dose up front, and I will take my epidural mixture, which we use 0.125% bupivacaine with 2 mics of fentanyl per cc. And I will take 8 cc's of that, and I will give that to the patient as a bolus. And then I'll go ahead and start a drip depending on their height. I personally run it around 10 cc's an hour. If they're taller, I'll run it at 12. If they're shorter, I'll run it at 8. And it just kind of depends on patient to patient. And I will start that right away. And I usually tell patients that it's not going to be like a light switch where the very next contraction you're pain free. It's going to be a gradual onset of this medicine as we start to fill that epidural space. And remember, the epidural space was just a potential space between 2 layers. And it's going to be able to absorb that volume in a horizontal direction. So if you can think about that epidural space, when I push volume in there, it'll spread first horizontally before it starts to go up their back. So it has to fill that potential space. And the lumbar region is going to have more acceptability in the epidural space than the thoracic region. And so it's going to fill first in that lumbar region a lot. And so you need that bolus dose up front. You need volume up front to be able to start coating those nerves. And that's why we use a lower concentration of local anesthetic, but a higher volume. And again, if I need to come back to redose them, I'm going to be giving volume to be able to do this. But I'll start that medication, and I tell them over the first 15 minutes, as the medicine starts to coat those nerves, you'll feel better and better and better with each contraction. But what you're going to be looking for is that it feels shorter. Each contraction feels shorter, that you're only feeling the peak and not the beginning and the ends of them. But they'll feel just as strong still. And then after about 15, 20 minutes, you should be getting to the point where you only feel pressure and tightening and not sharpness. And this, depending on how much volume we give, we want to get up to that T10 dermatome level like we talked about earlier. Now, if they're a lot closer to delivery, though, I usually tell patients this works by gravity. So if you're starting to have pain further down, we can sit you up and try to give you more volume, let that medication run down. Or if they're having more pain on the left or right side, we can tilt them on their left or right side and give that time for the medication to run down to that side of their body. And by gravity, that medication will usually start to go and coat those nerves. Now, the local anesthetic that we can use in this, like I said, we use at my facility bupivacaine. That'll last about 300 to 460 minutes before completely resolved. They'll start to get better before that, but if we shut it off, it'll take upwards of 300 minutes before it's completely resolved. Another long acting is ropivacaine. That's about 240 to 420 minutes. Some of the shorter acting local anesthetics are chloroprocaine, which would be about 100 to 160 minutes, and lidocaine would be about 160 to 200 minutes until complete resolution. And then, like I said, we mix fentanyl into our epidural mixtures as well. You can also give Duramorph or morphine derivative into the epidural space or the spinal space. Side effects of giving opioids here are going to be pruritus and then nausea, more so with morphine compared to fentanyl.
So a few adjuncts that we can add into our local anesthetics. There's different reasons we would add these. Some of them are going to be because of the density or duration. Some of these are because of just the duration, similar to if we're doing like a regional block that we're adding Decadron or adding Epi. We can do very similar things here with our epidural adjuncts. So remember that the more lipophilic, the faster the onset and the density of the block will be. So sodium bicarb will increase the non-ionized lipophilic form of the local anesthetic. So that will increase your onset and also the density when you have sodium bicarb added to this. You don't want to use this, as a reminder, with bupivacaine. That will cause a precipitate formation. And so you don't want to, again, use that sodium bicarb with the bupivacaine. If you want to use something to just prolong the duration, then we're really thinking about what can we do to, add something that would vasoconstrict the area. That's going to decrease the amount of uptake that's going to go into the bloodstream and take that away. And that's going to, again, just prolong the duration of the local anesthetic there. So you can do epinephrine, 1 to 200,000. Remember that 1 to 200,000 for easy math is 5 mics per mil. So that's really going to be our most common addition there to the epidural. Alpha-2 agonists are another option we can use to help with the density and duration of an epidural block. Really what's becoming popular here is using Precedex. You can also use clonidine, but Precedex really is the more favorable choice here for increasing that density. You're using a lot of Precedex at your facility, aren't you, Cole?
Yeah, I absolutely love Precedex. I use it whenever somebody needs a just tapped off or bolus or something because they're in too much pain. I will just come back and give Precedex, and it is a wonder drug. Love it. I'll usually give, if I'm going to go back and bolus somebody just to top them off, they usually will get, depending on how close they are to delivery, for me, anywhere between 12 and 20 mics of Precedex. And I usually mix that in with about 5 cc's of whatever local anesthetic I'm going to give. And within 10 minutes, they're comfy and they take a nap. They love it. I love it. It's great.
So now let's talk a little bit about some different issues that can arise if the catheter is not placed correctly. So the first one we want to talk about is a subdural block. So this will be where the catheter is threaded between the dura and the arachnoid membranes. And what is going to result here is a high block, in effect, basically. So they'll have inability to lift their arms. You'll see lightheadedness, fatigue. You'll see their blood pressure get really low or drop out. Usually, it's a delayed or gradual onset with more extensive sensory blockade, and you have more of a minimal motor blockade. You can even see this continue to track intracranially if you don't recognize this and stop. So you can see them have shortness of breath. You can even see differences or alterations in their consciousness level. So this is going to be a situation that if this is observed, you're going to immediately stop the infusion, remove the catheter. There's not a way that we're going to fix this, with repositioning the catheter. This is an immediate stop and removal. Let the symptoms subside. It's going to be a conversation if you'll try this again, depending on, how the labor is progressing and how the patient is recovered. But this is something that is, again, needed to be stopped immediately once identified.
And I guess we should add here too, it's the difference between what we've talked about earlier. We didn't really mention the arachnoid layer here because technically the arachnoid and dura layer are like boom, boom, back to back. And so if you're going to pass through the dura layer, you're also going to pass through the arachnoid layer, so what just causes your wet tap. But by random chance, sometimes, you couldn't even do this if you tried. You have to be under like fluoroscopy to even do this potentially. You can put that tip of the needle between the dura and the arachnoid membranes, which is like you're flirting with disaster just a second or a touch more to get the cerebrospinal fluid to come back. And all your signs will look good when you thread your catheter. I've had this happen twice to me actually early on in my OB career. And it was like a half hour later, just boom. They were like super lightheaded, could hardly lift their hands up, very lethargic. And you stop the epidural, and within 5 minutes, they were fine. It's very, very scary when it does happen, though. Uh, but it's not a spinal dose. It's not a intrathecal or subarachnoid dose, because they would have been like intubated and completely unconscious if you'd given that much into their spinal canal. But it is very scary when it happens, but it's called a subdural block, as Tanner said. Now, if you do go all the way through that dura layer, and it does go through, usually always, the arachnoid matter into the intrathecal space, this is where you want to place a spinal, but not with an epidural needle, not with the Tuohy needle. Now you're going to have that waterfall of CSF come back out, and you have some options here. It's telling what you'll do in that situation, because there's times where I've had it happen twice. Actually, one of them was my very first epidural I ever placed in anesthesia school, and I just pushed straight through. I was still learning and didn't realize I should stop there, and I went straight through outside the ligamentum flavum and went right through the dura. And I had a big waterfall come out, and my first instinct was to pull back really quick on the Tuohy needle and stop that flow, because I thought that would magically stop everything from going wrong if I did that. But I still left that hole there then. And the problem is, inside the body, that CSF is just leaking out. And what can happen then when that CSF leaks out is that cerebrospinal fluid is connected to the cerebrospinal fluid in the brain. And as you're leaking out through this hole you just made, you can imagine it's draining the CSF up in the brain. And it causes basically your brain to sag down towards the spinal canal. And it actually then creates that horrible headache, because everything's sagging down. It's not floating in the cerebrospinal fluid inside your skull, so to speak. And that's what causes that really bad headache. And this will last for several days. And it's not a guaranteed to happen if you have a dural puncture, but obviously it's much more likely. And the body has to heal and close that hole that we created before that headache will go away, so to speak. And so there's several things that we can do. If we think a patient is more at risk for it, but they're not full-blown symptoms of a bad headache, we can go ahead and give medication to enhance the production of CSF. Casentropin is a drug that we can do for that. We can also have the patient drink a lot of fluids and have caffeine. Caffeine is going to cause a vasoconstriction of the cerebral vessels, which will decrease the amount of pressure in the brain. So that's why if you're used to having caffeine every day and you stop, you get a bad headache, because now you have more blood going to the brain. If they rest or lie flat, usually the headache is a lot better, because the brain is not sagging downwards then. And then the gold standard is to do what's called an epidural blood patch. Now, an epidural blood patch is where you basically do another epidural on the patient. And you go in until you get to the epidural space, and then you have somebody sterilely draw 20 cc's of the patient's blood and hand you their blood. And then you will go ahead, when you get the Tuohy needle into the epidural space, rather than thread a catheter, you'll actually just push their blood into the epidural space. And the goal of it is to act as a tamponade, where it's going to block the hole from the dura matter that you created and prevent that CSF from leaking out. And the blood will just clot there. Now, you do this until the patient starts to feel fullness or pressure in their lower back or legs, usually around the 12 to 15 milliliter range. And instantaneously, about 90% of patients will feel that success and that immediate drop in that headache. If they don't, we can do it again, but we wait about 24 hours before we retry it. But there's a risk to this, because if we caused the dural puncture in the first place, then that probably means they were a hard epidural. So there's always a risk we can create a second hole by doing an epidural blood patch. But this is by far the gold standard, because it will immediately decrease that patient's pain if we do it correctly. The other option is, in the moment, if you did create that hole, rather than pull back the Tuohy needle, you can actually thread the epidural catheter into the spinal canal. And that will, in a way, make that hole smaller, because now you have a catheter through that hole. But we have to run this now as a spinal dosed medication and not an epidural dose medication, because you're directly impacting the nerves. And so you need to mark the crap out of this so that everybody knows, if you get off shift and the patient's still going to deliver and you have your next colleague take over, they need to know this is an intrathecal catheter and not an epidural catheter, because we don't want to cause a high spinal.
All right, so that's epidural. Let's move quickly into spinal. This will be a much shorter portion of this discussion, simply because we've already covered a lot of the same techniques that we'll discuss here with the spinal anesthetic. The goal here is to gain access to the CSF. So while we were talking about the epidural, where that's going to be, really something you don't want as you're placing the 2E needle. This is actually the goal of the spinal anesthetic, is to achieve that cerebral spinal fluid coming out of the intrathecal space. Same technique as an epidural, same positioning, same placement as far as placing your hands on the iliac crest and finding that L3, L4 level. You're going to be using typically a 25 gauge spinal needle is where we'll start instead of the large 2E needle. A lot of times, if you have a patient with spinal stenosis or they're elderly, many times it's popular to go to like a 22 gauge needle. And we can talk a little bit more here about the different types of blunt tips or cutting and those types of things. But it's a much smaller needle than the 2E needle. As far as actually placing this, you'll have an introducer for the 25 gauge needle. And so what that looks like is basically for lack of a better word, it's honestly like a ball pump needle that you see. And what this does is basically gives you like a sterile spot to be placing the needle through. So after you numb up the back, you're going to place this introducer into the back. And this is what you're going to place now your spinal needle through. So we're not going to be needing to go through skin, even though you're prepping the skin. You're not going to need to go through that with your small 25 gauge needle because you have that introducer already in place. If you're using a smaller or a larger, needle like a 22, many times you won't use an introducer. So again, this is just something that could be a tool that you use. It'll be in your kit as you're placing the spinal.
And I feel like too, the introducer helps because these 25 gauge needles are flimsy, and sometimes we're using 27 gauge needles, and you're gonna have a lot harder time getting through. So this introducer will get you halfway there. It'll get you engaged in some of those ligaments, and then you can just advance further from there. You're already on the right trajectory.
Exactly right. And that's another reason that you might want to use a 22 compared to a 25 is if you have more adipose tissue or you're going to have simply just like a longer way to travel when you're using these flimsier needles. Like Cole mentioned, it's difficult to even get through skin. And then as you're moving through the different layers, a lot of times you can get off track. And so that introducer is going to give you a really good starting point and a clear direction here. As you're placing this, you're going to, again, find that resistance in the ligamentum flavum, and then you're going to advance. Once you advance, you're going to take the stylet out of the spinal needle, and you should see CSF there as you get that loss of resistance. With the achievement of that cerebral spinal fluid, this is where you're going to want to see it drip. And then after that, you're going to attach your syringe with your local anesthetic in it. Many times we'll use the 0.75 bupivacaine for these OB procedures. A lot of times we'll also add Duramorph. You can add Precedex. You can use fentanyl as well. That's going to be a provider by provider preference, or even facilities use different cocktails. But you're going to be using some combination here of your local anesthetic combined with usually an opioid and maybe an adjunct like Precedex. The baricity is going to be basically telling you how that's going to compare to the CSF. And so it's going to determine where the medication goes, whether this is going to be, for lack of a simple way to think about this is this a heavy medication that we're giving where it's going to settle? Is this a medication that's just like the CSF that's going to just go and just mix in as it's equal? Or is this something that's going to rise? And if that's the case, then positioning the patient is going to be very important as you're getting them positioned for a surgery to make sure that you're getting good coverage. So again, that's something also to consider when you're giving the local anesthetic, understanding your baricity, understanding where your local anesthetic is going to go. One more thing I'll mention here too, when you're actually doing the spinal and you're actually placing the local anesthetic, it's still considered good practice as you're placing it to check midway through to make sure that you're still getting CSF return. Many times as you connect the syringe, you can, move your needle a little bit, or as you're injecting, you can move your needle a little bit. It's good practice that, you get CSF before, but then as you're injecting your medication that you'll check, and then you can inject the rest of your medication.
So once this is placed, we're going to instantly lay the patient back flat, and we want that medicine to be able to work up to around the T4 dermatome level. So around nipple line is what we're looking for. And usually they'll go ahead and lose their cold sensation first. That's how you know you're starting to take effect. They'll get a really warm tingling sensation down their legs. At that point, typically a Foley is placed, And once that Foley is in, I'll go ahead and test the patient. I'll make sure they don't feel any coldness up their belly. And then I'll actually tap them on the shoulder with a blunt needle so they feel the sharpness of it. And then I'll tap them starting on their legs, working up their belly. And I say, tell me when you feel the same sharpness. And they might feel touch, but I don't want sharpness until you creep up to closer to that T4 dermatome, and then they can prep and go ahead and get started. Now, things to watch out for. What can happen with neuraxial blockade? In just the last couple minutes here, for both epidurals and spinals, but more prevalently with spinals, is it causes arterial vasodilation, which is going to lead to a reduction in the peripheral vascular resistance. And then you're also going to see venous pooling, so it's going to decrease their preload, which is why we want a full tank, so to speak, on these patients before we start these blocks. We want to usually give them a full liter. And then also we can block the T1 to T4 cardiac accelerator fibers that branch out the T1 to T4 vertebrae. And those are the nerves that provide sympathetic stimulation to the SA and AV nodes. And so if that's starting to be blocked, you're going to have a lot of bradycardia that can develop. And so this altogether will cause a decrease in cardiac output, a decrease in blood pressure, and usually patients will feel very lightheaded and then get nauseous when this happens. So we want to keep patients within 20% of baseline. Typically, we'll treat this either with a phenylephrine push or a drip of phenylephrine for that alpha-1 antagonist to cause vasoconstriction again, or we'll use ephedrine, which will both increase the heart rate through beta-1, and then also will cause that alpha-1 vasoconstriction. Next, from the respiratory system, it's really going to have a limited effect on our respiratory rate, our PaO2, or PaCO2. But what I usually see a lot of is that you can potentially get this sensory blockade of their diaphragm and the movement of their intercostal musculature and abdominal musculature movement. And so as a result, they don't feel themselves breathing, even though they are. And they'll often have this experience of dyspnea where they feel like they're short of breath. And I have to remind them and say, look, here's your oxygen, here's your pulse ox, you're saturating fine, you're breathing, you just don't feel like you're breathing because you've lost that sensation at that level. And it is a very weird feeling for those patients. But this happens though, even though your minute ventilation is still maintained though. From a gastrointestinal standpoint, the gastrointestinal system is innervated by both parasympathetic and sympathetic nerves. So parasympathetically, it's innervated by the vagus nerves, and sympathetically through the T5 to L2 nerves. Now, the vagus nerve is going to increase gastric secretion, peristalsis, etc. Whereas the T5 to L1 sympathetic innervation, it's trying to inhibit those. So if you can think about this, if we do a neuraxial anesthetic, and we block the T5 to L1 sympathetic innervation of the gut, then the sympathetic innervation is now inhibited, and the vagus nerve can just act completely unopposed, which is going to result in increased peristalsis, increased blood flow to the bowel, increased contraction of the bowel musculature. And this is one of the reasons for the increased nausea and vomiting that we see under a neuraxial anesthetic. And then just very quickly to end, I did want to mention about a cerclage placement. This is one other thing that we can do from a neuraxial standpoint in the OB world. A cerclage is when somebody has an incompetent cervix and they go into preterm labor, they might place a cerclage to hold the cervix tight to allow further gestational age before delivery. And so for this, it's often done under spinal. Well, all they're doing is working at the cervix. So we don't need a full spinal dose like a C-section where we go up to the T4 dermatome level. You just need to work down in the sacral region, the S2 to S5 region, almost like you're in the second stage of labor. So what I do for these is do a spinal, but once the spinal is in, I leave the patient sitting up for 3 to 5 minutes because as Tanner said, it'll kind of, depending on what medication you're using, if you're using a higher voricity dose or medication than the cerebrospinal fluid, that medication will drop and it'll settle. So if you keep them sitting up, that medication will drop to the lowest point of the spinal canal, which would be in the sacral region. It'll numb those sections and those dermatomes. And I often tell patients they're still going to move their legs, they're going to feel touch and everything because we're just targeting the spot where they're going to be working at. And they'll feel the legs go up in stirrups and everything, but then they won't feel where they're working at their cervix. So that's what you can do for a cerclage with the spinal dose. I usually cut back to about 2/3 of my spinal dose than what I would do for a C-section, just because they don't need as much. But it works really well to do a saddle block in that case where we let that medication drop to the bottom before we sit them back. Well, hopefully this was helpful. Obviously, this is just a brief overview of OB neuraxial anesthesia, but hopefully this was helpful in terms of gathering some insight of why we would do an epidural and how we do that versus a spinal versus a saddle block, etc.